Good evening, all. So, with great pleasure, I welcome Dr. Jewell Joseph, MD Radiation Oncology, who works as an assistant professor in Christian Medical College, Vellore. He is the faculty of Impact HN course NCG. He completed his MD radiotherapy from Government Medical College, Thrissur, and his areas of interest are community palliative care and home-based care. We welcome you, sir, from our team. Thank you. Over to you, sir.
Thank you. Good evening, all. Without wasting much time, we'll get into the session. I'll share my screen now. I hope it's visible and I'm audible.
Yes, sir.
Yeah. So let's discuss briefly about emergencies in palliative care. So see, the word emergency in palliative care may sound a little bit ironic because palliative care is generally perceived as hand holding and all those kinds of symptomatic things where we take things calmly and slowly. But again, emergencies like in any other medical specialty can occur in palliative care as well. The only difference here is how we look into the emergencies. So coming to the emergencies, especially in a palliative care context, so emergencies can be considered as any condition that is a threat to either life or quality of life of the patients without an immediate intervention. So yeah, like in all medical specialties, all or surgical emergencies that we come across in our routine practice is also present in a palliative care situation. The only difference is how we approach these emergencies. So in palliative care especially, the things to consider when we are treating an emergency or when we are facing an emergency are, first, there should always be a preventive approach. So whenever a patient comes to us and whenever a patient is under our care, the first thing to ask is whether that particular patient is at risk of developing any emergencies. So in such a case, we have to take precautionary measures so that we don't go into that situation very quickly. For example, if there is a patient having a spinal metastasis who has a lytic lesion in a vertebra, so we can assume that in future he is at a risk of going into a vertebral fracture, which may in turn go into a spinal cord compression, which is a common emergency that we face in palliative care. So in such cases, we can actually provide him braces and give him lifestyle modification so that there is decreased weight bearing, and also we can stress on prevention of falls and etc. So this is how we reduce the risk of an emergency. But unfortunately, if we come across an emergency, the first question that we should ask is whether it is reversible or not. So whenever, see, in general, when we go into palliative care management, the three things that we generally consider as guidelines for managing any condition in palliative care are: one, correct the correctable; two, non-pharmacological measures; and three, pharmacological measures. So this is three steps that we go on. So whenever we come across something that is reversible, so we can by all means reverse it. That is the first question that we should ask: is it reversible? Second thing, even if it is reversible, is there a benefit? The difference, as I mentioned earlier, how we approach palliative care, emergencies in palliative care, is that we don't chase all the emergencies necessarily. For example, as like the example that we mentioned earlier, if there is a patient with multiple bone metastasis who is nearing the end of life, who is confined to his bed. So one day we find that he has developed like a weakness of his right lower limb. So we suspect a spinal cord compression. So we don't necessarily treat it because anyway the patient is non-ambulant, he is bedridden, and he's expecting his death in a few days. So in such case, that what would otherwise be an emergency in a healthy patient who is walking around now become just another condition which need not necessitate an emergency intervention. So the second question to ask is there a meaningful benefit? So the third thing, most important, one of the most important things is, what does the patient or family want? So in palliative care, we take pride in being patient advocates. So in all situations, we actually take into account what the patient wishes for, and we try to do our best to fulfill those wishes. So these are the things to consider whenever we come across an emergency in palliative care. So I'll just give some examples. So I'll have to make this statement in the beginning. This is by no means deep down discussion of each emergencies. What that will be too out of scope of this discussion. So what I'm trying to do is to list a few emergencies that we usually come across in palliative care and just give a brief look into the general management of those conditions. So before going into the emergencies individually, we can actually broadly classify them according to the system. So we can actually classify according to the system, namely, so neurological system, the emergencies that we usually encounter are spinal cord compression, increased intracranial tension and delirium. Respiratory system, main thing is airway obstruction. Vascular, superior vena cava obstruction and hemorrhage. Metabolic hypercalcemia and hyponatremia mainly. Skeletal would be pathological fractures and last but not the least, pain crisis and opioid overdose is another emergency. Look into one or two emergencies from each of the systems. So first thing, probably the most common emergency that we usually come across in the neurological system is malignant spinal cord compression. So it occurs in 3 to 5% of the cancers. It can either be a result of solid tumors or hematological malignancies. Solid tumors, the most common causes are prostate cancer, lung cancer, and breast cancer. So as you know, these are the most common causes of spinal, vertebral, or bone metastasis in solid cancers. So obviously, the chances of malignant spinal cord compression are more in the solid tumors. Hematological malignancies, most importantly, multiple myeloma, which usually affects, which is that tumor that affects the plasma cells, and one of the trademarks of one of the hallmarks of multiple myeloma is multiple lytic lesions throughout the skeletal system. The most common site is thoracic spine. So the most common site is the thoracic spine. The reason is, see, one of the most common cancers throughout the world in females is breast cancer, and one of the most common cancers in throughout the world in males is lung cancer. So these, as we mentioned earlier, are among the most important causes of bone metastasis as well. So since both of these are in the thorax, there is especially in the breast cancer through the base and venous plexus directly into the thoracic spine. So naturally, the most common site of vertebral metastasis is the thoracic spine. And there can be many symptoms of malignant spinal cord compression. Examples being pain, mechanical instability of the spine, and neurological deficit. All these can be caused by malignant spinal cord compression. So we'll just look briefly into the pathophysiology of spinal cord compression. So initially, there will be a tumor coming outside the thecal sac, which is causing a compression. So this compression can cause venous stasis. Venous stasis will eventually lead to vasogenic edema. Vasogenic edema leads to ischemia and finally the infarction of the cord. So as you can see, here is a tumor going into the thecal sac, but there is only an indentation. Then the tumor enters the thecal sac, so it actually goes around the least path of resistance, that is usually around the spinal cord. And finally, there is spinal cord compression. So this is the pathophysiology of malignant spinal cord compression. So coming into the spinal signs and symptoms, one of the most common symptoms of malignant spinal cord compression is back pain. It is present in 95% of the cases, and in 40% of the cases, there can be a radicular pain as well. So why this is important is, usually pain occurs much before the neurological symptoms occurs. So why that is important, we'll come to in a minute. So just keep in mind that back pain or general pain in that particular region is the most common symptom. So there can be neurological symptoms and autonomic symptoms. Neurological symptoms being weakness, loss of sensation, all those things. Autonomic symptoms like bowel and bladder dysfunctions, etc. So examination-wise, there may be an elicitable spine tenderness, and again, if that is progressed, there can be neurological and autonomic signs also. So the gold standard in diagnosis will be the MRI. So X-ray is also a useful tool when there is an associated fracture of the vertebra, but most important thing is MRI. The gold standard would be MRI. So another important point that I would stress is, in 1/3 of the patients having malignant spinal cord compression in a particular site, there can be another site in the spine where there is another lesion or compression. So whenever you come across a patient who is having a spinal cord compression, always screen the entire spine. rather than just taking an image of that particular region of the spine. So there is always worthwhile screening the entire spine because there is a 33% chance of another site having a fracture or a compression. So just keep that in mind. So coming to the treatment, first would be bed rest to avoid further exacerbation of the symptoms. Pain can be addressed with opioids and adjuvants. So NSAID, see, the thing is what we usually, whenever there is a bone pain or fracture, one of the first choice of analgesics that we uses the NSAIDs. So should we use NSAIDs in this kind of situation or malignant spinal cord compression is an important question. So the only thing to keep in mind is that malignant spinal cord compression usually is treated with steroids that we'll come to in a minute. So whenever we are prescribing NSAIDs along with steroids, we are all aware that there is an increased chance of gastrointestinal bleeding. So NSAIDs can be an important measure in producing pain relief, but always make sure that when you see a patient with malignant spinal cord compression on treatment, so make sure that he or she is not already on steroids or be planned for starting on steroids in the immediate future. So in that case, you will have to stop NSAIDs and go back to opioids and other adjuvants. So for bowel and bladder symptoms, you should use laxatives, digital rectal evacuation, and catheterization to for the associated bowel and bladder incontinence. The treatment of the cause, malignant spinal cord compression, mainly the steps are steroids, surgery, radiotherapy, and chemotherapy. Steroids, what it does is, see, whenever there is a tumor, there is always a peri-tumor edema and some inflammation surrounding the tumor. So what steroids does is it actually reduces the peri-tumor edema and inflammation, thereby there is a chance of the compression of the spinal cord being reduced. And also in some hematological tumors, steroids have, like lymphoma, steroids has a direct anti-tumor effects, which can actually reduce the size of the tumor itself. But the primary idea of giving steroids in not only in spinal cord compression, anywhere, wherever there is a tumor compression, which we'll come to in the coming slides, wherever there is a compression of the tumor, we always give steroids with the idea that it will reduce the peri-tumor edema and surrounding inflammation and reduce the compression. Second thing would be surgery, especially when there is a spinal instability. If the vertebra is unstable, or we are expecting it to produce further trauma, surgery is a good option to fix the spine and to prevent further damage. Radiotherapy is a useful option. It can actually reduce the pain, and it can actually reduce the tumor size also and prevent the worsening of symptoms and regain some functions as well. Chemotherapy is another hematological malignancies where we expect a rapid response to chemotherapy. Usually chemotherapy is not the first line. The first line treatments would be either steroids, surgery, or radiotherapy. And steroids, whenever we give radiotherapy, we usually give steroids along with it to prevent the radiation-induced increase in inflammation for that particular time. So chemotherapy is usually not the first line, but in certain hematological malignancies, chemotherapy is usually very useful. So coming to the a brief summary of steroids that we usually use. The usual steroid that we use in all these conditions, whenever I mention steroids, please take it as dexamethasone. That is the usual steroids that we use. It has anti-inflammatory and anti-tumor effects. The usual dose of steroids that we give for such patients is 16 to 24 milligram per day. So once a definitive treatment is done, we can actually taper of steroids. The problem with steroids is whenever we give steroids for tumors or malignant compressions or something like that, the effect of steroids actually, the effectiveness of steroids actually come down after 1 or 2 weeks. So the longer you give steroids, the lesser will be the effects. So it is always beneficial to give steroids as pulses and taper it down very fast, and then whenever there is an exacerbation, we can actually give steroids again. So always whenever is give gastroprotection by means of either H2 blockers or proton pump inhibitors, and concurrent use of NSAIDs should be avoided with steroids, because as I mentioned earlier, there is increased chance of gastrointestinal bleeding. So other treatment options I mentioned: radiotherapy, surgery, and chemotherapy. So coming to the prognosis, the most important prognostic factor is the pre-treatment ambulatory status and the time of initiation of treatment from the onset of motor deficits. So just remember the point I mentioned earlier, the importance of identifying pain in malignant spinal cord compression. So as we can see here, the most important prognostic factor is pre-treatment ambulatory status, the motor function of the patient that was present before the treatment, and the time of initiation of treatment once the motor deficit starts. So it is said that once 48 hours pass after the onset of motor deficit, it is very difficult to reverse, or it is very difficult to achieve the pre-treatment ambulatory status. So that is why it is very important to identify pain, because in malignant spinal cord compression, pain occurs usually days or weeks before the development of motor deficits. And once motor deficits develops and 48 hours or something like that passes, it is very difficult to go back into the pre-treatment status as well. So just keep that in mind. Every back pain in a patient with a malignancy should be treated as malignant spinal cord compression unless proved otherwise. So it is always better to err on the side of caution than to feel sorry later. So we'll come into increased ICT. So basically, this is the same thing. Instead of there is a compression in the spinal cord, it goes into the brain. That's all. So it can be because of metastasis to brain or meninges or primary brain tumor. So the most common, again, see, the thing is, the most common tumor in brain is not a primary brain tumor. It is always a metastasis. Just remember that. So the most common causes of increased ICT would be brain metastasis rather than a primary brain tumor. And the most common tumors that causes metastasis to brain are lung, breast, and melanoma. The symptoms you'll already be knowing. The symptoms of increased intracranial tension, headache, vomiting, seizures, altered sensorium, etc. Treatment against steroids. The idea of giving steroids, as always, is to reduce the peritumor edema and the surrounding inflammation. So it can actually reduce the edema, and often in brain meds, steroids produce a drastic effect, at least for the initial few days. So there, we usually give mannitol, osmotic diuretics like mannitol as well. But the recent studies suggest that their effects very soon plateaus off. So it is not routinely given nowadays, but there are some centers that where we still use diuretics. So again, options will be surgery, radiotherapy, and chemotherapy or targeted therapy. Surgery would be if there is a single brain metastasis which can be operated out. Surgery is an option. Again, radiotherapy can be either SRS, stereotactic radiosurgery, or whole brain RT. So similarly, if there is only a single focus of brain metastasis, we can actually give a concentrated radiation to that particular point. And this is called stereotactic radiosurgery. So if there is multiple brain mets throughout the brain, so we should irradiate the entire cranium, which is called whole brain radiotherapy. So again, chemotherapy and targeted therapy. So especially there are new targeted therapy agents especially in carcinoma lung, which can actually cross the blood-brain barrier and produce effects on brain mets. The one important problem with chemotherapy generally is the chemotherapeutic drugs very rarely penetrate the blood-brain barrier, and so most of them are ineffective in brain mets. That issue is somehow sorted by newer targeted therapy agents, which can actually cross the blood-brain barrier. So coming to the symptomatic management, analgesics can either be paracetamol or NSAIDs. The issue with opioids is all opioids technically will decrease the seizure threshold. So there is an increased chance of seizures when we give opioids to a patient with brain mets. Especially tramadol is notorious in this regard. So if avoid opioids and give paracetamol or NSAIDs or step 1 analgesics to these patients. So in case opioids are necessary, we usually avoid tramadol and give morphine because tramadol is notorious in reducing seizure threshold in such patients. Some adjuvants can also be given. So while giving adjuvants, always keep in mind that you must be familiar with the WHO analgesic ladder. So adjuvants are usually in many cases antidepressants like amitriptyline, mirtazapine, etc. So technically, all antidepressants also can decrease the seizure threshold and increase the risk of seizure. So while giving adjuvants for these patients, we should keep that in mind as well. So we have just completed the central nervous system. So we'll go to the respiratory system. The first thing is airway obstruction. So airway obstruction can be acute or subacute, and it can also be intrinsic or extrinsic compression by a tumor. So subacute airway obstruction usually is slowly developing. So it usually presents as shortness of breath. There can be some stridor also, which is typically an inspiratory finding. So management of subacute airway obstruction is oxygen, steroids, as I mentioned earlier, the same mechanism of action, opioids plus benzodiazepines. So opioids, basically what they do is opioids, especially strong opioids like morphine, which actually reduces which reduces the work of breathing so that the patient will feel more comfortable breathing, and that difficulty with breathing will reduce. Benzodiazepines can also be tried along if there is an increased anxiety component along with the breathlessness. So one usual doubt regarding opioid that we generally have is whether opioid will cause respiratory depression. So it may be ironic to at least some of you when I say that opioids is very useful in shortness of breath, especially in subacute airway obstruction. See, the thing is, for opioids to reach that particular level, it should be either taken with a harmful intent or it should be a massive overdose. In a carefully titrated dosing regime, opioids almost always never cause respiratory depression. And also, even there is an overdose through mouth, it is very difficult to attain such high blood levels of opioids to cause respiratory depression. It can only be usually achieved by parenteral opioids. But again, in a carefully titrated regime, they almost never cause respiratory depression. So radiotherapy, when there is an extrinsic compression of the tumor, while giving radiotherapy, it can actually reduce the size of the tumor and relieve the obstruction. So tracheostomy, if there is an upper airway obstruction, tracheostomy is an option as an emergency thing. But if there is a long course like that of a subacute airway obstruction, the risks and benefits of tracheostomy need to be discussed with the patient, because there's maybe in many cases there may be a stomal recurrence, or it will only if the primary disease is very badly responding to the therapy, tracheostomy will only be increasing the suffering of the patient, prolonging the suffering of the patient. The benefits and risks of tracheostomy should be discussed with the patients and the family whenever there is time for the same. So acute airway obstruction is a very severe, suddenly developing condition where there is severe progressing dyspnea and hemodynamic collapse. So in this situation, unfortunately, there is nothing much that we can do to relieve the obstruction or reduce the symptoms. So what we can usually do is we can actually sedate the patient and educate the family and support hand holding and being near the patient and provide as much comfort as possible. So unfortunately, this is a very, very drastic situation, very unfortunate situation where we usually cannot do much regarding the symptom as such. We can actually sedate the patient and support the family. We are now going into the vascular thing. So superior venal cavity obstruction. So this, you must be familiar with these symptoms. So whenever there is a superior vena cavity obstruction, so there will be dilated veins or just there is facial puffiness, scleral edema, conjunctival edema, all those things. In severe cases, there can be cerebral edema as well. So one important sign that we usually tell in the MBBS viva is pulseless neck veins and all those things. So you will be familiar with this thing. So this is superior vena cavity obstruction. So the most common causes of SVC obstruction are bronchogenic carcinoma, lymphoma, mediastinal germ cell tumor, etc. So the treatment again, symptomatic treatment will be steroids, as I mentioned earlier, radiotherapy and chemotherapy. Radiotherapy and chemotherapy to modify the disease. See, the one thing that I want to mention about superior vena cavity obstruction is just because superior vena cavity obstruction develops, that doesn't mean that the patient is only for palliative care. So in lung malignancies, even with the superior vena cavity obstruction, if the general stage of the tumor is in the curable stage, the prognosis is almost the same as a tumor without SVC obstruction. So just keep in mind that just because a patient has SVC obstruction doesn't mean that the disease is incurable or the patient is only for palliative treatment. So it's a very well curable disease if the general stage of the disease is in a curable state. So the idea of giving diuretics is to reduce the fluid load, but again the benefit is questionable. Bronchodilators can also be tried, but again the benefits are questionable. So some general measures we usually use in SVC obstruction is avoid IV fluids through upper limbs, because we don't want to overload the SVC again, and keep the patient in propped up position, which may help with the breathing difficulty. So the next vascular complication would be hemorrhage. It can either be due to tumor infiltration to blood vessels or marrow infiltration, which causes thrombocytopenia and resulting in bleeding indirectly. So it can be either a minor bleed or a major bleed. So general measures of minor bleed would be transfusions, vitamin K, fresh frozen plasma, etc. So bleeding control can be achieved by hemostatic RT. So the radiation in a lower dose given to control the radiation, control the bleeding. We can try medications like tranexamic acid. Site-specific bleeding, like if there is a rectal bleeding as a result of some proctitis, or they can give organ plasma coagulation, steroid and sucralfate enema. All these can be tried in radiation proctitis. All those things can be done. The site-specific measures, general measures, and bleeding control measures. So major bleeds, as I mentioned earlier, similar to acute airway obstruction, there is little, unfortunately, there is only little that we can do to control the bleeding. So it more is comfort care. So we'll give opioids to the patient, sedate the patient, dark towels, because major bleeds is a very traumatic event for the caretaker. So to avoid that sight of blood, we use dark towels and support the family. So this is what we usually do in major bleeds. So another important complication is pathological fractures. So pathological fractures are most common when obviously in cancers causing metastasis to bone. So the most common would be lung, breast, prostate, and myeloma. The treatment can be surgical fixation, bisphosphonates, etc. Surgical fixation, whenever there is a fracture, we can surgically fix it. Bisphosphonates and denosumab. Bisphosphonates will actually increase the calcium absorption into the bone. Denosumab is also a rankle inhibitor, which also increase the bone calcium uptake, and probably like in a way of strengthening the bone. For symptoms of pain, we can give analgesia and adjuvants. See, one important thing is whenever there is bone metastasis to a patient, if that bone, so it is always important to identify the risk of the patient. So there is actually a scoring system known as a Merrill scoring system for pathological fracture prediction. It takes into account the site of the bone lesion, pain, X-ray appearance, and size of the lesion. So as I mentioned earlier, if the site is a weight-bearing site, so like see, upper limb is not actually a weight-bearing site, the risk is lower. But if it is in the lower limb, or more specifically in the trochanteric region, it is a weight-bearing site, so the risk of fracture is more. Again, more pain is an indicator of a more severe lesion. Lytic lesions obviously will have more risk when compared to blastic lesions. And size of the lesions, if more cortex is involved, there is an increased chance of fracture prediction. So the scoring we usually use to predict the risk of pathological fractures. So coming into the next system, malignant bowel obstruction. Malignant bowel obstruction occurs in 3 to 5% of the patients. It actually can occur anywhere from esophagus to rectum, but the most common site is small bowel. See, one interesting thing is the most common cause of bowel obstruction is not actually a cancer in the bowel itself. It is usually ovarian cancer, because ovarian cancer is very prone for peritoneal mets and all. So ovarian cancer usually is the most common common cause of malignant bowel obstruction, closely followed by colon cancer and others. Usually in advanced malignant bowel obstruction is a poor prognostic factor, and once it develops in an incurable disease, the median survival is only 1 to 3 months. So according to the extent, the bowel obstruction can be either partial obstruction or a complete obstruction. Based on the level, it can be a single site of obstruction or a multiple site of obstruction. So this multiple obstruction especially is common in carcinoma ovary, where there is a diffuse peritoneal disease. So there can be multiple sites of obstruction as well. So coming to the pathophysiology of obstruction. So whenever there is an obstruction, there will be proximal distension, because the bowel contents cannot pass through that site of obstruction. So the initial response of the body is to try to push that contents through the obstruction. So there will be increased peristalsis, increased secretion in an effort to lubricate the contents through the obstruction. And whenever there is increased peristalsis and increased secretions, there will be bacterial overgrowth in the increased secretions. So which eventually leads to increased gas production, which again will dilate the bowel, which it goes again into the proximal distension, and this cycle actually continues. This is a vicious cycle if the obstruction is not relieved. So there will be pain, bloating, nausea, vomiting in this particular stage. So as obstruction goes on, there will be increasing distension of the bowel. So once this distension goes on for some time, there will be associated inflammation of the bowel. So inflammation causes bowel edema. Bowel edema will again, what happens is there will be bowel edema, there will be decreased blood flow, and this cycle will again continue. Whenever there is edema, there will be again increase in obstruction. So finally what happens is then the obstruction is not relieved and the bowel becomes edematous and stretched out, the blood vessels actually will be compressed, which eventually leads to ischemia of the bowel. So bowel ischemia will finally leads to perforation and peritonitis, sepsis, and multi-organ dysfunction syndrome. So this is basically the natural history of bowel obstruction. So we can see that in the initial stages, when there is increased peristalsis and the body is trying to push that contents through the obstruction, there will be increased colicky pain, increased visible gastric peristalsis. All those signs can be there. But once it reaches the stage of distension and there is bowel ischemia and bowel death, the pain, that colicky kind of pain is not as evident. The major sign will be distension, because the bowel is dead and it cannot no longer can contract. It will only be the main problems will be of distension, not because of pain. So see what again, the symptoms will actually depend on the site of. See, if there is an upper GI obstruction, say for the gastric outlet, the ideal, the easiest way of relieving that obstruction would be not to push the contents all the way down. The easier way would be to vomit it out. This is the easier way. On the other hand, if there is an obstruction lower down in the large bowel, it will be very difficult to push the contents all the way back and cause vomiting. The easier way would be to push it down. So according to that, the symptoms will also be varying. So in proximal GI obstruction, the vomiting would be usually early and severe, and the distal GI obstruction, the vomiting would be late and less. So distension is usually absent in proximal gastrointestinal obstruction, because whatever content is there, the patient usually vomits out. So there is minimal distension usually. But in distal GI, the distension is present, because if the contents cannot pass down, it will actually get collected in the intestine. There will be significant distension. And pain in the proximal GI, the pain is mostly in the upper central abdominal region, and distal region is usually in the lower abdominal pain. Constipation, proximal GI is less because there is more of vomiting, and distal GI, the usual initial symptom is constipation. To the investigations, the usual thing that we do to confirm the bowel obstruction is X-ray. This is the classical example of the bowel obstruction where there is a air fluid level. So another important thing is X-ray can confirm bowel obstruction, but if you want to know the cause of the obstruction, CT would be the ideal investigation. It has 93% sensitivity and 100% specificity. But again, whether to go for a CT is another question. If that is an incurable disease, it is a very advanced disease, and if the patient is terminal. So whether to go for a CT is the decision that a clinician should make based on the clinical scenario. So another important investigation that we can use in this situation, especially in upper GI obstruction when there is significant vomiting, would be to go for electrolytes, serum electrolytes. So there may be some associated electrolyte imbalance also. It can actually prove beneficial in improving the patient's general condition. So the idea of treating bowel obstruction would be, to just keep these 2 points in mind. So 1/3 of the obstruction actually relieves on itself. Second thing is, in many conditions which present as an obstruction, the obstruction is not complete, but only there is only incomplete obstruction. Points should be our guiding principles of managing bowel obstruction. So as I mentioned earlier, 1/3 of the obstructions relieve by themselves. So the first step would be to rest the gut, because if you rest the gut in 1 or 2 or 3 days, there may be spontaneous resolution of the obstruction. You can actually give sips of fluids. So IV and subcutaneous hydration, whether that is beneficial. So I remember in my PG days, whenever a patient comes with obstruction, the 3 things that we usually write in the case sheet is NPO, NG tube, and IV fluids. I think you must have all done the same at some point of your career. But the thing is, NG tube is only beneficial in upper GI obstruction when there is a large volume vomitus. Otherwise, it's not beneficial. IV and subcutaneous hydration, yeah, if you feel that the obstruction can be relieved, or you are planning for some surgical procedure, for a short time it is beneficial. But if it is a non-reversible obstruction or is a terminal patient, IV or subcutaneous hydration is may not actually improve the quality of life of the patient. So nasojejunal tube is actually something that we can consider if there is an upper GI obstruction, like a gastric outlet obstruction. Putting a tube directly into the jejunum may provide a pathway for feeding the patient. So the surgical measures would be the gold standard if possible, resection, bypass, and stoma. So there are some palliative procedure also, including stenting. So candidates for surgery would be single obstruction patients with single obstruction, patients who have good response to anti-cancer treatment, localized disease, young patients with good performance status, and benign causes of obstruction. So if all these things are not possible, then we'll have to go for the pharmacological measures. So the idea of pharmacological measures is, as I mentioned earlier, most of the obstructions that we see clinically, complete obstruction, but incomplete obstruction. So the idea would be try to facilitate bowel emptying. If that fails, try to prevent secretion so that the symptoms actually will not worsen. So these are the two main principles. So to facilitate bowel emptying, what we can try give is a trial of steroids. Again, as I mentioned earlier, steroids can actually reduce the peritumor edema and inflammation, and sometimes the obstruction may relieve with steroids. Along with that, we can give prokinetics like metoclopramide or domperidone and try to increase the peristalsis and push the contents through the obstruction. The important thing is steroids, if we give, if it is not benefiting after 2 or 3 days, there is no point in continuing further, we should discontinue. And again, with prokinetics, if there is an increase in colicky pain, when we give prokinetics, it is an indication that the obstruction is not getting relieved, and we should immediately stop the prokinetics. Otherwise, there is a theoretical chance of bowel going into perforation if you keep on giving prokinetics against an irreversible obstruction. So once this facilitate bowel emptying step fails, our next step would be to prevent secretion so that the signs and symptoms of the obstruction does not worsen. For that, the drugs that we usually give is anticholinergics like Buscopan or hyoscine butyl bromide, and somatostatin analogs like octreotide. The third strategy would be to treat associated symptoms like pain with analgesics and antiemetics with vomiting with antiemetic agents. So the next, we are coming to the end of the discussion. So we'll discuss some electrolyte imbalance also. The most common, probably one of the most common things that we come across in palliative care is hypercalcemia. So hypercalcemia is usually associated with lung, breast, myeloma, and lymphoma. It can actually be associated with bone metastasis, or it can actually come as a paraneoplastic syndrome as well. So there are many proposed mechanisms of hypercalcemia in malignancy. There can be increased parathyroid-related peptide secretion. PTHRP is parathormone-related peptide. There can be local osteolysis in case of bone mets and excess vitamin D secretion. These are all the proposed mechanisms of hypercalcemia in malignancy. So clinical features are, you must have heard the saying, moans, groans, abdomen, you will know, right? So stones, abdominal pains, there is a mnemonic like that. So the neurological things would be irritability, confusion, sedation, and delirium. GI would be anorexia, nausea, vomiting, and constipation. Renal would be polyuria and dehydration. So these are the clinical features of hypercalcemia. So management will be based on severity. So mild is usually 10.5 to 11.9 milligram per deciliter. Moderate is 12 to 13.9, and severe is more than 14 milligram per deciliter. So again, one important thing is whenever you measure calcium, always send an albumin along with it, because there is if there is hypoalbuminemia, so we might falsely detect the calcium at a lower value. So according to, if there is a hypoalbuminemia, you should get the corrected calcium with this formula: measured calcium plus 0.8 into 4 minus serum albumin. I'm so sorry for this typo. This is 4 minus serum albumin. So always measure albumin along with calcium to get the corrected calcium level. So treatment, basically we have three strategies: increased calciuresis, reduce parathormone, and reduce bone resorption. So increased calciuresis can be the sole strategy in mild hypercalcemia. So it can be because of it can be by hydration and diuretics. So diuretics previously was routinely used for hypercalcemia management, but recent evidences question their effectiveness. So hydration is definitely a strategy. So for reduction of parathormone, we can use calcitonin, and for bone resorption reduction, we can use bisphosphonates and denosumab, which will actually take the calcium from the blood and deposit it in the bone. So hyponatremia, next electrolyte imbalance. So we divide hyponatremia into three classes: hypervolemic hyponatremia, hypovolemic hyponatremia, and euvolemic hyponatremia. So hypervolemic hyponatremia occurs in congestive cardiac failure and cirrhosis. So here what happens is there will be decreased cardiac output. So there will be decreased perfusion of the kidneys. So since there is decreased perfusion of the kidneys, there will be activation of renin, angiotensin, aldosterone system. There will be increased sodium uptake and water uptake. But whatever water is reuptake from the kidneys is going into the third phase because the heart is not able to pump the blood. So what happens is, so the fluid is getting collected in the third space, and at the same time, the carotid baroreceptors will detect the low pressure because there is decreased pumping of the heart. So ADH secretion will be stimulated. So renin, angiotensin, aldosterone, RAS system is already stimulated. Along with that, ADH is also stimulated. There will be increased free water uptake as well. So the increased free water uptake will be out of proportion to the sodium reabsorption. So eventually, there will be hyponatremia. So especially in congestive cardiac failure, development of hyponatremia is a poor prognostic factor. It just tells you that the heart is more and more, heart is failing more and more because it is not able to pump the blood properly. The next is hypovolemic hyponatremia. One of the things that we usually come across, it is because of the electrolyte loss from the body along with the fluid loss, vomiting and diarrhea. There will be hypovolemia along with hyponatremia. SIADH or syndrome of inappropriate ADH secretion can cause euvolemic hyponatremia. Why is it euvolemic? Because there will be increased ADH secretion and there will be increased free water uptake into the body. But the renin, angiotensin, aldosterone system is active, and also there is another hormone called atrial natriuretic peptide. So those two things act together to maintain the volume by throwing out sodium, by natriuresis. So they'll throw out sodium, along with that they'll expel water and maintain the volume at euvolemia. So that is the reason why the urine has increased. So one of the hallmarks of SIADH is there will be euvolemia, there will be hyponatremia, but there will be increased urinary excretion of sodium, right? So that is because the other systems, there is increased ADH secretion, and then the other systems are trying to maintain the body volume, the blood volume, by natriuresis, by throwing out sodium along with water. So that is why there is increased sodium in the urine. So hyponatremia, the diagnosis is less than 135 milliequivalent per liter. Symptoms is usually less than, occurs when less than 120 milliequivalent per liter. Life-threatening usually is less than 105. So basically the treatment of hyponatremia will depend on the level of hyponatremia and also the development of symptoms. So we usually divide into mild, moderate, and severe. Anything more than 130 is mild, 120 to 130 is moderate, and less than 120 is severe. So along with the symptoms also, the management will be dictated by the level of sodium and the development of symptoms. The major symptoms would be anorexia, malaise, irritability, muscle cramps, confusion, seizures, coma, etc. So management, just I would like to mention the thing is SIADH, syndrome of inappropriate ADH secretion. The important thing is water restriction. Because the pathology is increased free water absorption. So 3% saline, and there is one thing called tolvaptan, which is an antagonist to ADH, vasopressin antagonist. So while we correct hyponatremia, with 3% saline, the important thing to keep in mind is that the correction should be 4 to 6 milliequivalents per 24 hours. So otherwise, there is a chance of central demyelination syndrome, or previously known as central pontine demyelination. So there is a chance of pontine demyelination if we correct more rapidly. But the ideal thing is to keep the correction at 4 to 6 milliequivalents per 24 hours. So there is a formula for hyponatremia correction where we find the total body water, sodium deficit, and then we find the total sodium deficit and the volume of 3% saline, and the rate of infusion would be at the rate of 0.5 milliequivalents per liter per hour. So last but not the least, pain crisis and opioid overdose is an important emergency that we can come across in palliative care. But I'm pretty sure that you must have had classes on pain management, opioid overdose, pain pests, and all. So I'm not going into that thing. So I'm nearing the end of my time. So take-home messages would be any condition that causes patient distress in an emergency. Patient distress in palliative care is considered as an emergency. So the question to ask is, will the intervention result in a meaningful benefit? So just because we have a hammer, we need not go on hitting all nails. So whether the intervention will result in a meaningful benefit or not, then always try to be patient advocates. and to give importance to the patient wishes whenever possible. Thank you.
Thank you, sir, for that presentation. So we have few questions in the chat. So I'll read it for you. The first question was, are bisphosphonates used for spinal cord metastasis?
Yeah, not typically spinal cord metastasis. It is usually not specifically for spinal cord metastasis. It is usually given for vertebral mets, which are causing spinal cord compression as a secondary thing. See, if there is a vertebral bone mets, so there is an increased chance of developing spinal cord compression in future if there is a fracture and all. So in such cases, we can use bisphosphonates to prevent fracture, prevent skeletal related events, but not specifically for spinal cord compression.
There is another question from Hina Saini. She asks, indication of bisphosphonates, are they given in all cases of pathological fractures or any specific condition?
Yeah, we usually give bisphosphonates for all pathological fractures. In the sense to, one thing is there may be an associated hypercalcemia and to prevent further damage of bone. So we don't specifically, previously we have been taught that we should use bisphosphonates only in some lytic bone metastasis and not in sclerotic bone mets. But currently we use bisphosphonates for all conditions, all bone mets.
Sir, the other question was, can we use zoledronate in bone pain?
We can try. So there are studies showing that zoledronate can have some effect in reducing bone pain as well. So yes, but it is not a first line thing. We should definitely use analgesics. But yes, zoledronic acid has a role in bone pain. But to what extent it is useful, I am not very sure. But definitely it has a role. So it will not be used as a sole agent for control of pain in bone pain. But definitely yes.
Okay, sir. So these were the questions in the chat. If anyone would like to unmute and ask your questions, please.
Yeah, I am Dr. Nandini.
Hi, ma'am.
What I want to know is you talked about all the emergencies, no? So
Yeah.
This is in a hospital setup or a home setup?
All these are in a hospital setup, ma'am. The thing is, some things we can actually treat in home setup as well. But the primary context of all my discussion would be in a hospital setup. So the thing is,
there will be in every hospital there will be a section like this is the palliative care ward, or this is a general medicine ward, this is the ICU ward. So palliative care section will be totally different than the general physician's ward.
Not necessarily, ma'am. Not necessarily. That I can actually tell that it can vary from center to center, but not necessarily. A palliative care ward, the approach to the patient is a little bit different, but the treatment need not be any different from a general medicine center as well.
No, because you mentioned about that dark towels and caregiver. So if there is a hospital setup, you're talking about everything about hospital setup. If there is a hospital setup, we have doctor, professional, nurse, and then there are no caretakers there. Then it is taken up by the sister or a person who's qualified, nurse who's qualified. Or dark towel and bleeding, major bleeding comes when the person is at home setup and there is a caregiver.
Every hospital, I mean, as I know, ma'am, there will be one. At least in our hospital in palliative care wards, we definitely allow one bystander, one caretaker. We don't usually keep the patient alone unless the patient is in an ICU, which is something that we never do in palliative care. But we always have a caretaker along with the patient.
No, my point was if we is in a hospital setup, the caretaker will not take any decision. He'll call the nurse. First thing he will do is he will call the nurse. He will not handle the emergency.
Ma'am, yes. The dark towel is only to prevent the sight of blood from the people who are near to the patient. So it can be either at home care or at hospital. See, ma'am, whenever there is a terminal bleeding, the patient is nearing the end of life. So at least in our hospital, there is definitely a caregiver with the patient, and the sight of the blood will be very distressing for the caregiver who is along with the patient. So whether the nurse put the dark towel or the caregiver put the dark towel, but dark towels definitely are, we usually employ in terminal bleeding just to prevent the sight of that blood gushing out from the wound or something like that.
And what if the person develops emergency in home setup? Then what is the protocol?
The thing is, ma'am, that is where we should be vigilant so that we should identify the risk patients who are at risk of developing emergencies. So in such cases, if we identify early, we'll actually make a plan. We should educate the caregivers of the possible emergencies that can develop, and we can actually teach them according to that. So if they cannot actually handle by themselves, there is no way they should actually bring the patient to the hospital.
Okay, then you advise the home care the patient to be shifted to hospital for further management.
Not always, ma'am. Not always. See, the thing is, ma'am, if we get the patient very early, and if we can actually foresee and identify the risk of developing patients, and if we are pretty sure that the patient is not going to benefit by a hospital admission, and if the family has some financial constraints or some logistic reasons, so all these things should be considered and a plan should be made. So if we have enough time to do all these things, so we can decide on the place of care, decide on the place where the patient should be taken care of, and make a plan accordingly. See, if a patient suddenly develops something at home, and if we have not seen the patient before, we cannot suddenly go to the home and do all these things. So the patient will have to be taken to the hospital. But if we have enough time with the patient before that, so that we can discuss with the family, we can have multiple team meetings with the family, and we can foresee the complications and make a plan and educate the patient relatives to do these are the things to be done in such a situation. That education can be there. So it all depends on the decision making with the family. So the time that we have with the family, the time that we have with the patient, prior to this emergency happening.
Okay, thank you.
Thank you.
Okay, sir. Thank you. So we have two more questions.
Yeah.
Sir, how economical are bisphosphonates as compared to antibodies like denosumab?
Yeah, it's denosumab. Actually, I think it is around 20,000 per dose. While bisphosphonates is much cheaper. So, yeah, denosumab actually has benefits, but it is costly. Injection solitronate is bone meds is 4 mg. The dose is 4 mg. We can give.
Thank you, sir.
Thank you.
These are the questions. Anyone of you like to ask a few more questions? We have time till 6 p.m. Otherwise, if there is no questions, then we can move with the case presentation for today. Okay. So I invite Dr. Shreya Shri to present today's case.
Good evening, everyone. I'm Dr. Shreyasi. I'm a radiation oncologist in Kokilaben Hospital, Mumbai. Am I audible?
Yes, ma'am, you're audible.
Okay, fine. So if you can please share the PPT.
Can you see the slides?
Yes,
Yeah.
we can see.
Yeah.
Yeah, so you can start with the presentation, ma'am.
So if you can please go to the next slide. So our patient is a 40-year lady. She is a known case of CA breast. Next slide, please. So she presented with us with complaints of lower back pain since last 1 month. Pain was not relieved with analgesics and it gradually progressed. It became persistent and progressive band-like in the lower back. And gradually she developed unsteadiness while walking for 2 to 3 days. Next slide, please. So the past history is patient is a known case of carcinoma left breast, PT2, N2A-MX, TNBC, that is triple negative breast cancer. She had initially presented with left breast lump 2 years back. On evaluation, PET-CT had shown a large left breast lesion with uptake. There were multiple satellite nodules, and also there were axillary lymph nodes in the PET-CT with uptake, which was suggestive of metastasis. So, in view of a locally advanced breast cancer, she received neoadjuvant chemotherapy with 4 cycles of AC followed by 12 cycles of taxanes. Following this, she underwent modified radical mastectomy in 2020. And the HPR showed that it was a multicentric tumor, and even after chemotherapy, there was not a good response. There was a large residual tumor, and 8 nodes in the axilla were positive, and it was a triple negative breast cancer. After this, she received external beam radiation to the left chest wall and left SCF, that is supraclavicular fossa, to a dose of 40 grain 15 fractions till December 2020. She was not on a regular follow-up after that. On presentation, on examination, her general condition was fair. She was an average built lady. She was wheelchair bound in view of weakness and lower back pain. There was no pallor, icterus, sinuses, or clubbing. There was no palpable lymphadenopathy anywhere. CVS and RS and per abdominal examination are normal. On CNS examination, there was bilateral lower limb weakness. Power was 4 out of 5, and there was no sensory deficit. And also there was no bladder or bowel dysfunction. Next slide, please. So the treatment and the significant investigations were, after she came, an urgent MRI was advised. MRI showed there was a metastatic disease impinging on the thecal sac at the level of L3, L4 vertebra. There were diffuse vertebral involvements at multiple vertebra. However, there was no spinal cord compression elsewhere. In view of these findings, she was advised to do a full metastatic workup. PET-CT was not affordable for her. Sonography of abdomen showed that there were multiple liver metastases also. She was started immediately on steroids, injection dexamethasone 8 milligram TDS, and also on analgesics, tramadol tablet 50 milligram thrice daily. Next slide, please. So coming to the psychosocial aspects, our patient is a young lady, middle-aged lady more, working as a house help. Her husband works as an auto rickshaw driver, and he's an alcoholic. She is currently in denial. She is not able to accept why this happened to her, why the disease progressed, even after completing the entire treatment 2 years back. For completion of the treatment, they had already sold their land and ornaments, and now they do not have any savings to continue further treatment. Next slide, please. So the medications received by her were, immediately she was started on steroids, dexamethasone 8 milligram thrice daily, and gradually it was planned for tapering. She received tramadol, PAN 40, and cremafin. External beam radiation was given with palliative intent to L2 to L5 vertebra to a dose of 20 grain 5 fractions. She was being considered for palliative chemotherapy in view of disseminated metastatic disease. And also she was advised physiotherapy for her lower lips and Taylor's face. Next slide, please. So the main concerns of the patient was she has 2 daughters, and she was worried that they might also have this disease. She was worried that due to her lower limb weakness, that might not improve, and she will be a burden to her family members. She already exhausted her family savings, and she does not want to spend any more for her treatment. Now, also, she was worried that it will be difficult to get her daughters married once her relatives and everyone comes to know regarding her current disease status, that she has progressed, and they might be afraid that same might happen to their daughters also. Next slide, please. So to summarize, Mrs. ABC, she's a 40-year lady working as a house help, known case of breast, carcinoma left breast, TNBC, adequately treated for the primary disease, however, with progressive metastatic disseminated disease, now presented with spinal cord compression. Next slide, please. So our points of discussion would be, is she the ideal candidate for palliative care? Though the metastasis there is metastasis in vertebra and liver, she is otherwise stable. So should she be considered for palliative chemotherapy? And knowing her financial status, will starting and continuing with palliative chemotherapy be a good choice for her? Also, coming to the family concerns, her husband is an alcoholic. So how to counsel for the rehabilitation and her treatment support, and also how to counsel regarding societal pressure that she is so worried. Thank you.
Thank you, Doctor. So I would like the participants to come up with your comments and discussion. We have Dr. Jewell here, so you can ask your
I
questions.
would suggest for her, what I would suggest for her daughter, because she's very much concerned about marriage of her daughter. So I don't know what are the daughter's age, but she can be taught about the awareness of the self-examination of breast. And there are some screening tests which are available. Suppose the age is more than 35, she can go for mammography. Then she can go for other tests like pap smear, these are all tests which are done for oncology. For
We
CA cervix, we have pap smear. We have mammography. We have other genetic evaluation. You can do karyotyping. So there are a lot of other genomic studies which are there, and we are in a year of 2022. So people are not aware, but there are some very advanced tests which are available, which can be done if the family is educated and they have some amount of money.
Yeah, I agree. The screening and self-examination is definitely needed. However, they were not affording for genetic testing that is actually available, and many people opt for that. But her family is not affording for that. So yes, self-examination and awareness is definitely the choice.
What I have to tell what my point is and what my thinking is, today there might not be money, but might be that after 6 months she gets a good job. So it is not necessary that karyotyping has to be done now only. We can just give her education that in future when you have money, suppose she gets a job, she earns money, and in 1 year time or 1.5 year time, when she has money, she can do the test in her own life whenever she gets proper time and the financial support. But my duty is to educate the family that these tests are available, and when the proper time comes, you go for it.
Yeah, yes, definitely.
But those, excuse me, the BRCA testing, the mother also has to do it. And then when the daughters do it, when you compare both the results, that is much more valuable than just having the daughters. Because if the mother is positive and the daughters are not, that is more significant than just doing the daughters. That's what I understand. So at least the mother should, I mean, if she's bothered about people thinking that it's her daughters would be inheriting the
yeah, so, sorry to interfere. The thing is, BRCA testing, I think there are certain guidelines for who is an ideal candidate for BRCA testing. So just because her mother is a breast cancer patient, need not, it need not necessitate that BRCA testing in the daughter. So in the sense, it is basically like especially in this financially constrained situation. So I think self-examination and other things would be the better thing. And we can actually educate if suppose there is like as I mentioned, there is a suitable alliance for the daughter who is just backing out because of the fear of hereditary breast cancer syndrome. So they can actually be counseled and educated regarding the risks and all those things. That is ideal. I think, just because, especially in a financially constrained situation, genetic testing for this patient, it's not necessary actually. It may be considered as an opt-in kind of thing, but not necessary. In comments regarding the first question, is she ideal candidate of palliative care? Am I audible?
Yes,
Yes,
you're
yes, you
audible.
are
Yeah.
audible and clear.
Yeah, the thing is, the way we understand palliative care is, it is no longer an end of life kind of thing, end of life care. So currently the understanding of palliative care is it starts right at the diagnosis and goes towards, goes until the end of the disease. So it's especially if there is an advanced disease or something, from the time it is diagnosed, so palliative care actually starts. But the weightage actually goes, varies according, there is a famous graph, I cannot actually show you now, but in the sense, in the beginning, when the disease is diagnosed, the curative kind of treatment takes the upper hand, but palliative care is still there. But as the time progresses and if the disease is not responding and the disease is progressing, the curative or the disease modifying component will actually come down, and uh, the, the weightage for palliative care will actually go up. Palliative care suddenly comes up at a particular point. It should ideally be started from the diagnosis itself. So definitely, all patients with, especially with an incurable or an advanced disease, are candidates for palliative care. So even before they go into like an incurable kind of state. So definitely yes. Further palliative chemotherapy, I'll just share my personal opinion. I am currently not a practicing radiation oncologist, although I did my training in radiation oncology. So if there is metastasis in vertebra and liver, and if she is stable, and if the family can afford, there is no harm in trying palliative chemotherapy, especially with carcinoma breast. Yes, it is a TNBC, but I think it can, if she can actually tolerate, it can actually result in a meaningful survival benefit. It need not be a very toxic regime. It can either, even a single agent oral therapy like capecitabine can actually make a difference. But the thing is whether it will actually provide a financial burden to the patient. Also, it should be a shared decision. So we should be clear whether we should explain to them what are the benefits and risk. So see, an IV regime would require frequent hospital visits and something like that. But an oral thing, as I mentioned, just for an example, like an oral capecitabine or something, which won't actually necessitate frequent hospital visits also. So the thing is, there are a lot of schemes, government schemes available. If we can actually get the patient into one of the schemes, palliative chemotherapy is definitely a possibility, especially in this kind of a disease, although it is metastatic. I think, practicing radiation oncologist can actually comment. Dr. Shreya can actually comment in this. But I think
Yeah, we did give that option to the patient, and we also
Yeah.
sent for financial support to, there are several NGOs and organizations helping out. Yeah, that's definitely an option.
Yeah. Rehabilitation of husband. Yeah. One thing I wanted to tell is all these things, it should ideally be handled by a multidisciplinary team. So as I just got Dr. Maruk just mentioned, social worker, definitely. Social worker, psychologist, palliative care nurse. So one thing in palliative care is it should always be a team whenever possible. And as doctors, we are very deficient in dealing many situations. So it's not like entirely our forte. So our social worker can come into the picture, palliative, so psychologist, all these things, all these people can actually help. So we may not be able to deal all the situation. Yeah, rehabilitation is definitely an option. So as doctor mentioned rightly, social worker will definitely make a difference in this case. Counseling regarding societal pressure is the problem with genital testing, as we mentioned earlier. So even if we produce a genetic testing report to a suspicious, for example, if an alliance come to the family and they are suspicious that this patient is actually, the daughter will actually get it by hereditary thing. Even if we produce a report and tell that she is BRCA negative and she is not at risk of developing breast cancer, it may not mean much to them. See, if the patients are from a very well-educated background, so there may be more awareness regarding all these things. So if they are not from such a background and they have a lot of suspicion and fears regarding them. Showing a report actually may not mean much of a thing to them. So it's more like talking, counseling, etc. So yeah, a social worker, if, we can actually go a step further. If we have a family, they are planning for an alliance who are just holding back because of this thing, we can actually talk to them and explain them that these are the situations and these are the chances that she is getting. All those things can be done. Yeah. Other comments are welcome, please. Dr. Dora Babu has rightly mentioned financial help from NGO and addressing logistical arrangements for thorough evaluation and likely prospective management. Perfect. See, but the thing is, in almost all states, as I know, there are some government schemes to help these patients. So there are options to consider. Any opinions on how to counsel regarding societal pressure regarding doctors' marriage? Any other ideas? You can unmute yourself and speak up also.
Yeah, I would just like to comment that this is a very this is faced quite often, especially in the low economic strata of the patient. This is quite evident, and one or two cases we have seen that the family of the guy was actually willing, and they had come and they had a combined discussion with the doctor and all, and they finally got married. And counseling session with both the families is an option, but then that might not be feasible for all.
Yeah, true.
I have one question. Now, in this case, doing the BRCA testing would be ideal, right? But we know this patient is not able to afford it. So is it correct? I mean, should we mention that this should be ideally done to the people when knowing that they cannot do it?
Ma'am,
So how would they respond to it? I mean, it's like...
Yeah, the ideal definition actually is a little bit tricky here, ma'am. So the thing is, if we are strictly following the guidelines, there is no indication for BRCA testing in this patient. Correct me if I am wrong. So I have not gone through the guidelines recently, but according to the guidelines, a mother alone having a triple negative breast cancer is not an indication. According to the guidelines, it's not an BRCA testing. So the ideal thing would have more of a social context than a medical context.
No, what I'm saying is that suppose there is a treatment, even if this is a test, but suppose there's a treatment which is available and we know the patient cannot afford it. So is it correct to mention it? Because if we don't mention it, it's not correct. I mean, you can say ABCD is available, but because a lot of times if you say this is the best, but we can't give it to you, they are not feeling the relatives feel we haven't done the best.
Yes, that is actually a wonderful question, ma'am. And this is something that we really face in our day-to-day practice, this dilemma between offering everything possible and giving them the feeling of guilt versus hiding something from them. We know that if they cannot afford, I don't have an answer for that. It is actually really a great dilemma, and I don't know if I have an answer for that. See, and this actually it's highly into that ethical kind of debate, and we don't have. We have this issue multiple times. So especially if it is a tertiary care hospital, if it's an educational institution, so some hospitals make a point that, so we can actually argue that it is ethical to give the patient all options. Downside of it is that if we know that the patient cannot afford, for example, if you offer an immunotherapy option to a patient who can hardly afford their daily bread, it only gives the additional guilt to the patient and not anything. But yeah, I seriously don't have an answer for this, ma'am. That is really a very difficult ethical question.
Because there's a lot of legal, I mean, I don't know, I was just thinking somebody
Yes.
may come back and say you never mentioned this thing was available, and possibly, I don't know. I'm just, that's
Definitely,
what I was thinking. Thank
definitely. That's a great question. It's the definite a lot of ifs and buts in that. But again, yeah, it's not something that we can come up with a clear answer, I think.
you. Okay, thank you.
I feel we should have more awareness regarding the NGOs and the support groups which contribute in a very small manner, in small financial support. If we tell the treatment part and we know what is the socioeconomic status of the patient, that means they are not affordable. With that, we should also give all the financial support groups which can help them, so that they can make decision in 1 week or 15 days that if they approach the financial support people, they will be able to take the medical help.
Yeah, that is definitely looking at it, ma'am. But again, one issue with that thing is with the newer agents like immunotherapy agents and all. So even the cost of these injections, it's like 1 lakh per injection. So even with the additional added help, so this is, and these are not something that we can stop with 1 or 2 cycles. It has to be continued. So even with this, if they can somehow find the money for 2 injections and we need to stop after that, so there is no point in doing that also. So even with all these things, certain treatments are out of reach for a majority of our common public. So that is a sad truth, even with all the government schemes. So in Kerala, the government offers up to 5 lakhs. So that most of them will be used up with the initial treatment. So once the patient progresses and if we offer an immunotherapy, which will cost 1 lakh per injection. So even with all the help, so there are some treatments which are truly out of reach for all these people, unless we get them into a clinical trial, or the companies will sponsor the expenses of that particular. That is a sad truth that we are facing.
Any more questions? If not, we can wind up for today.
I think here the 4th principle of palliative care comes, which is justice. It is the making the proper justification for the as compared to the availability of the resources.
It can actually be interpreted in either way, ma'am. Justice is actually the we can also argue that if a particular treatment is available for a rich person, it is really an injustice to make it unavailable for a poor person. So yeah, it's all very tricky, ma'am. I don't think I have a straightforward answer to this, but again, I think this is a call that each one of us has to make individually in each clinical scenario. Thank you for bringing that up, bringing that topic.
Good evening, everyone. I would just like to, hello, am I audible? Yeah.
Yes,
I would just like to add actually that this was a very convenient and significant aspect actually, that most of us, like these NGOs or some small scale institutions or some organizations which are actually into giving support, giving maybe financial support or helping in providing volunteer caregivers to such patients, most of us, including the patients, they do not know whom to turn up to. Like even us being as doctors are not very well versed with who are different organizations who can. So maybe there can be some database or some other format in which even we and that's the service providers and the service beneficiaries, they can actually access such a the list or maybe a database to whom to turn out to. I think that would be very beneficial to everyone. So some campaigns or some awareness programs maybe could be done. Some digital platforms could be used for this, to just create this awareness amongst everyone that even if needed, you can turn out to such institutes or organizations for help. I think that would be very helpful.
That is an excellent point, Dr. Priyanka. So see, in our institution, I'll tell what happens. We have in medical oncology department, we have a secretary. So who keeps a database of all these things, and that person has contacts with all these people, NGOs and other organizations providing funds. So we actually send them to him. So he'll actually make arrangements according to the eligibility criteria. So I don't think that will happen everywhere, but this is an excellent point. The thing is, if you ask me, I am only aware of 1 or 2 sources of this financial help, as you rightly mentioned. So definitely it is, yeah, we should know where to look up, where to look also. That is an excellent point.
Yeah, thank you, sir.
I hope most of the doubts are cleared because it was a brainstorming session and the participants were also very interactive today, came up with many questions, and I thank Dr. Jewell for being there for the whole session and answering each and every question. Thank you so much, sir.
Thank you so much, Dr. Jewell, for joining us.
Thank you. It was a pleasure to be here again. Thank you.
Thank you, sir. Thank you all for joining us today. We'll see you on next session. The feedback link will be shared to your WhatsApp group. Thank you all. Bye-bye.